Webcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome to the second webinar from the CANM. My name is Nicolas Rondeau-Lapierre, and I will be your virtual manager for tonight's session. Let's give ourselves another minute to wait for more attendees, and then we'll get right into it. Thank you. All right, everyone. Thanks again for joining us tonight. My name is Nicolas Rondeau-Lapierre. I will be your virtual manager for tonight's session. I am accompanied with Dr. Salim Yunus, that will be tonight's moderator, and Dr. James Mastrianni, that will be the speaker for tonight. Let's go really quickly over a bit of the setup for tonight's session, so everybody knows how the session is going to work. Just try to familiarize yourself with the control panel as an attendee. Ensure that your audio is working so you can hear everyone well. Attendees are automatically muted so you're not able to talk like we are. In the handout section, there is a protocol, an attendee protocol that you can download in French and or English, just to give you a couple of tips. If ever the audio is not working or the video is not working, you could always download that, and it's quite helpful. There will be a Q&A session after Dr. Mastrianni's talk, and moderated by Dr. Yunus. We are more than welcome to send any question that you want, maybe just throughout the presentation. Please feel free to send out your questions so we don't get them at once at the Q&A session. And after that conclusion of the session, and we will wish you almost a Happy New Year, because the third webinar will be after in 2021. So with no further ado, I will give the floor to our tonight's moderator, Dr. Salim Yunus. Dr. Yunus, you have the floor. Thank you. Have a great session, everyone.
Hello, everybody, and welcome in our second CNM webinar. Our speaker today, Dr. James Mastrianni. It was a pleasure to introduce him today in our lecture. I have an impressive introduction for him. He's a professor in neurology and the director of the Center for Comprehensive Care and Research on Memory Disorder at the University of Chicago. He did receive his PhD in pharmacology prior to his medical school at McGill University. After that, he did his internship and neurology residency training at the University of Pennsylvania. Then he did complete a fellowship in the research at the UCSF under the guidance of the Nobel Prize, Dr. Stanley Brusner, in the physiology and medicine for his discovery of the prions. After his fellowship, he did move to University of Chicago, where he developed the Center for Comprehensive Care and Research on Memory Disorder. And in addition to his clinical and teaching roles, Dr. Mastrianni conducts a clinical and basic science research to better understand and treat a neurodegenerative disease. His clinical research efforts are broad, but mainly including the drug trials for Alzheimer's disease and the application for neuroimaging in the clinical diagnosis of Alzheimer's disease. It's a pleasure again. Welcome, Dr. Mastrianni, and the stage for you right now. Good luck for your presentation.
Okay, thank you so much, Dr. Yunus. Thank you for inviting me to this program. So what I'm going to do is try to fit everything in on time. I do tend to say more than I plan to say during a talk. but I'll do my best to stay on track and keep you hopefully informed and give you some maybe new information or to just secure some old information that you may have forgotten. So my disclosure is really not much to say. I'm not getting any personal kickback from any industries relating to any of the agents I'm going to talk about, and but I have been a recent site director for as PI for clinical trials with AstraZeneca and Lilly and Roche and Genentech. Okay, and sorry, I was trying to get something out of the way there. And I'm a consultant for CVS Caremark for their dementia medication program. Okay, so first I just want to kind of briefly introduce the topic and talk about some general aspects of Alzheimer's disease. So as I'm sure most of you know, this is very common dementia. It's the most common of all dementias, but certainly the most common over the age of 65. Under 65, frontotemporal dementia is actually more common. There's almost 6 million people affected in the US, and I think the last count for Canada was about 900,000 patients. And it's predicted by the year 2050 that 14 to 16 million people in the US will have Alzheimer's disease. So this is going to be a major health burden and financial burden to the healthcare system here if there's no treatment for Alzheimer's disease. The majority of the people are over the age of 65, but there are still young people who get Alzheimer's disease. And so we have to be aware of that. We see lots of patients in their 40s, 50s, and early 60s with Alzheimer's, so you can't discount it at those ages. There is, however, an age-associated risk. So the older you get, the greater your risk to Alzheimer's disease. And if you look at this chart, about 10% of the population over the age of 65 may be developing Alzheimer's disease. If you look at the population over the age of 85, the numbers are really significant. 40 to 50% of people beyond age 85 are Alzheimer's, have Alzheimer's disease. And you can see that from the time point of 2020 to 2050, because of better health and longevity, people are living longer, the older population is increasing, and the baby boomer population is also coming of age. So this is, again, going to be a major burden to our healthcare system. There are genetics associated with Alzheimer's disease. There's two kinds of genes that provide risk to Alzheimer's disease. The first is a risk gene, and that's the apolipoprotein E gene. And essentially, there's 3 alleles of normal alleles that you can have, and the E2, 3, and 4. And E4 allele imparts a significant risk for Alzheimer's. So if you have one allele, that increases your risk anywhere from 2 to 4 times the normal population. If you have 2 alleles, it's more than additive, so your risk can increase up to 12 times. So that's a concerning risk factor to have, and we don't, however, test for apolipoprotein E in the clinic when we're making a diagnosis of Alzheimer's disease, primarily because you can still have the risk E4 allele, but not get Alzheimer's disease. So it's not a guarantee. On the other hand, for the causal genes, it is a guarantee. So if you have a mutation in one of these 3 genes, the amyloid precursor protein gene, presenilin 1 or 2, your risk is essentially 100% that you're going to develop Alzheimer's disease. And typically, those patients that carry a gene defect in one of those genes gets an early onset form of Alzheimer's, so usually under the age of 65. Women are affected more than men, and really more than twice as much. And the good news to that is that it's because women live longer, and that's the primary reason for that. But there is probably some gender effect also that people are starting to recognize. African Americans here are also at greater risk, and that's likely because they have increased comorbid burden of hypertension and diabetes. This can actually promote the development of Alzheimer's disease. Whenever families ask, what's the prognosis when somebody's diagnosed with Alzheimer's disease, I use this range of 5 to 15 years because I don't like to predict how long a person's going to live. But on average, it's anywhere from 5 to 9 years or so that people will typically live with Alzheimer's disease. So what I thought I'd do to illustrate what Alzheimer's disease is all about is to give you a little snippet of a video of a patient of mine with a very typical presentation of Alzheimer's disease. I'm going to turn the volume up a tiny bit. And should hold on to 3 words for me, okay? The words are apple, table, penny.
What's the last one?
Penny.
Penny?
Mm-hmm.
Okay.
Say that for me.
Apple, table, penny.
Good. Okay. And now I'm going to point to a few things in the room, okay? So I want you to remember these. One is the yellow piece of paper there, okay?
Okay.
Another one is the overhead light, okay? And then thirdly is the paper towel dispenser, okay? All right, so point to those 3 things. Okay. Okay, very good. All right, and then tell me who the president is right now.
This is Trump.
Yeah. Okay.
Is it?
You tried to forget it, but you...
You're right on that one.
Okay, all right, very good. And then just tell me what a zebra is.
It's a funny horse.
Okay, all right, that's good. Can you describe it for me?
Looks like a horse and it's got stripes.
Okay, very good. All right. And now tell me what the 3 words were that I asked you a little while ago.
Nothing's coming.
No. Okay, if I give you a little hint, one was a fruit. Remember which fruit it was?
I'm going to take a wild guess. Banana.
Okay, it's an apple. All right, okay. So, apple, table, penny. Okay?
Apple, table, penny.
Correct. Okay.
It is.
Okay, and then I pointed to 3 things in the room. Do you remember that? Okay, so you can see, how quickly she was forgetting, and that's really one of the key features of Alzheimer's disease, rapid forgetting. Patients really have a problem with learning or encoding, consolidating new information. So when they go back to try to retrieve it, it's just not there. So this is an insidious disease that's gradually progressive. It kind of sneaks up on people. It starts off slowly. Maybe episodic memory problems that people have. Family and friends will recognize it before the patient does, typically. In very early stages, sometimes patients who are, most often I see high functioning individuals, they do recognize some memory problems, but often there's a lack of insight from the patient. So usually the memory problems may be spotty here and there, and they might be forgetting a conversation, repeating a story, maybe within a week or a few days, and then it becomes more and more frequent, and then the repetition is one of the key features that people will recognize that can occur on the order of just a couple of minutes, every minute or 2. Misplacing personal items, losing some important things, leaving them at restaurants, maybe a pocketbook or a wallet or something, but also just around the house, just forgetting where people place things. Sometimes this becomes a real challenge for families because the patient thinks, number one, that people are moving things on them. So they tend to start to hide things. They can accuse people of stealing things. So then they hide them in very secure places that no one would ever look. And so the car keys or something important may take months for people to find. Language is also impacted in many of the patients. Sometimes in some forms of Alzheimer's disease, language is the primary thing that's affected in very early stages of the disease. Typically, people will complain about word finding difficulties, maybe not being able to put sentences together. Visuospatial impairment is manifest by getting lost in the car. In the early stages of disease, it may be, being able to go from one place to another and generate that map in your head. As the disease progresses in late stage, some patients will have difficulty finding their way around the house and getting to the bathroom. Physical function is usually preserved in patients in early stages, except for some rare forms of Alzheimer's disease. The mood is often altered, and depression is a common feature of Alzheimer's disease. And this can be enhanced by the way the family responds to the disease. So if patients are forgetting to do things, forget to take their medications, or not taking care of their clothes, throwing things on the floor, not being as neat as they used to, or whatever it might be, the family maybe, it may feel overbearing to the patient that they're confronting them and constantly bringing attention to the memory loss, and so depression can set in for that reason. But some people will have frank delusions and paranoia. Sometimes it's very difficult to manage paranoia about people coming into the house at night, and even visual hallucinations with seeing people in the house, which is very difficult to control. The disease creates a functional impact, so eventually the cognitive problems will affect how a person can maintain themselves. They lose their independence. They can't keep track of their medications. Some will forget to eat. If they're still working, the work performance goes down. A patient today lost his job because of his memory problems. And other things suffer, and it becomes difficult to maintain your activities of daily living. So when we approach a patient, we think about the diagnostic criteria. These, in 2011, the National Institutes of Aging and the Alzheimer's Association came up with a new set of diagnostic criteria. The last time there were diagnostic criteria put together was 37 years before this. So it was time that they were updated, primarily because we've learned a lot about Alzheimer's disease, and there are new ways to look at it and understanding the biology. I'm not going to labor on this because most of you are not going to be seeing patients directly, but in order to make a diagnosis of Alzheimer's, we have to make a diagnosis of dementia first. And so dementia is simply just, I think of it in simple terms, that it's cognitive or neuropsychiatric symptoms that impair your work or play. So once these become significant enough to affect how you enjoy life or how you work and how you maintain your independence, then that meets criteria for dementia. We have to obviously do our homework and demonstrate some cognitive decline in two major cognitive domains. But once we do that, then we can look at the diagnosis of Alzheimer's disease. And so we think of Alzheimer's as I mentioned, an insidious disease, insidious onset with gradual progression. It doesn't happen, one day you don't wake up and all of a sudden your memory is gone. This is a gradual disease. There should be, either by history or direct observation, worsening in cognitive function, and this can be measured. or reported by a family member. That's a reliable source. Now, there's the most prominent cognitive deficits in Alzheimer's disease in the beginning of the disease can be two major categories. So the one that we think about most often is the amnestic category, and that's the one like that woman that I just showed you. She has very significantly impaired learning and recall. But there are non-amnestic presentations of Alzheimer's disease, and these are sort of the atypical Alzheimer's disease presentations. Here, a patient can present with just a language disorder, which is called primary progressive aphasia. Typically, it's called logopenic variant that is most often associated with Alzheimer's disease. There are some patients who present with a visuospatial problems, and this is the posterior cortical atrophy syndrome. So these patients may have visual perception difficulties, problems with reaching, and some other features of visual perception, such as simultagnosia. And then there's a third category of executive dysfunction, patients with primarily executive dysfunction, and this is called the executive variant of Alzheimer's disease. And so this is when Alzheimer's, you can see that Alzheimer's will present in various brain regions. So the language, we think of left side, left dominant. In the visuospatial, it's going to be more posterior parieto-occipital association cortex. And then in executive dysfunction cases, the frontal lobes may be more affected. So when we do a routine diagnostic, our routine for the workup of patients with Alzheimer's, primarily, which I don't list here, these are the tests that we do, but the history gathering is probably one of the most important things, is to get good history from an informant. The patient, we always involve the patient, but we have an informant who can back up what the patient is stating and add to it in detail. But we do certain testing, and primarily cognitive testing is done to determine if there is in fact a cognitive disorder. Usually in the office, we do a screening assessment with the mini-mental state exam, and of course the Montreal Cognitive Assessment from my alma mater. And so the MoCA is illustrated here, and what you can see is the MoCA has 30 points to it, just as the mini-mental. But the mini-mental is primarily language-based and doesn't really take into account executive function, which the MoCA does quite well in the first section. So this is a task of connecting circles, alternating numbers and letters. So it's kind of like a multitasking thing. And this, you need good executive function. How people approach copying the cube also addresses some degree of executive function, although it's primarily visuospatial. And then putting together a clock, putting the numbers in and setting the hands, again, executive function. So when we're trying to discriminate between a frontotemporal dementia that's going to have generally some executive dysfunction versus Alzheimer's disease that normally doesn't have a lot of executive dysfunction, this test can help us, but it may also cause problems when we're not sure if it's the executive variant of Alzheimer's disease. The memory task is harder than the mini-mental task. So here there's 5 words that the patient has to remember, and they get 2 trials to try to register the words and remember them. And then we interrupt them, distract them with some other tasks, and then ask them the 5 words. And so you can see that this is quite a bit more difficult than in mini-mental. We ask just the 3 words as I asked that woman, maybe a couple of minutes lapse in between. So the memory has to be significantly impaired to pick it up with a mini-mental, whereas this is more sensitive. So patients are then sent for blood tests. We check primarily in older individuals for reversible causes of dementia, and then neuroimaging. We rely on the MRI and the CAT scan in some people who are intolerant of MRI for either medical reasons or are too anxious, and often add an FDG PET to the workup in cases that are a little difficult to diagnose. And then there are other special studies that we might address if it's a very difficult case. Okay, so this is just kind of a picture and overview of the two major imaging studies that we use, the MRI. The key feature that we're looking for in the MRI is hippocampal atrophy out of proportion to cortical atrophy. So this is a normal brain, obviously, and this is a brain with a significant amount of atrophy. In this case, it's not excuse me, obvious that the hippocampus is atrophic out of proportion to the cortical atrophy, and that's often the case. In early stages of Alzheimer's disease, though, because the disease kind of starts out in and around the hippocampus, sometimes we can, and actually often, I would say, we can see hippocampal atrophy out of proportion to the cortex. And if we do see that, then that is a helpful diagnostic clue. The problem is, again, we may see this more diffuse atrophy, and as you get older, the atrophy is quite variable. So people in their 80s, some can have a pretty significant amount of atrophy and not have any cognitive problems, and others can have an equal amount of atrophy and have significant cognitive problems. So the older patients get the more difficult it gets to use the MRI as a diagnostic assessment. So in those cases where the MRI doesn't help, then we move to FDG PET. And if we see the typical feature of Alzheimer's disease, we see hypometabolism of the temporal and parietal lobes. And in particular, if we also see involvement of the precuneus and the posterior cingulate, then that's a very typical picture of Alzheimer's disease. So the PET scan, FDG PET, can help us discriminate primarily between frontotemporal dementia and Alzheimer's disease, because obviously the FTDs will have a decrease in signal here versus relatively intact posteriorly. And then some other variants of Alzheimer's disease, maybe. But it's limited, as is the MRI, in that it doesn't provide any information about the underlying pathology of disease. So just this is my wow slide to show you, how significant and damaging Alzheimer's disease is. Here's a nice, pretty full brain with tight sulci and plump gyri. And here's an Alzheimer's disease brain, and you can see how significant the atrophy is with a widened sulci, and that the temporal lobe and the parietal lobes are primarily affected. So if we look at the pathology of Alzheimer's disease under the microscope, we see two key features of pathognomonic features of disease: the neurofibrillary tangles and amyloid plaques. The amyloid plaques represent amyloid of a short peptide of 42 amino acids. It's an extracellular accumulation of these amyloid fibrils that come together as a plaque. The neurofibrillary tangles are intracellular, and these represent hyperphosphorylated tau. So tau is a protein that helps keep microtubules in the neurons together, which helps with passing nutrients from the cell body to the axon terminal. And when the tau accumulates and causes dysfunction of the neurons, that is a primary feature that relates to the neurodegeneration. It's thought that it's known, that the pathology starts, again, as I mentioned, in and around the temporal lobes and hippocampus, and then spreads posteriorly through the parietal and anteriorly through the frontal lobe. And eventually, as the disease progresses, encompasses a pretty large area throughout the brain. There you can detect amyloid and the tau accumulations. It's thought that the amyloid plaques, although they're the key feature of Alzheimer's disease, they likely initiate or trigger the disease process that then causes the hyperphosphorylated tau to accumulate. And it's been shown that the manifestation of disease seems to correlate better with the accumulation of tau. Although some studies recently with amyloid PET maybe suggest some other features or some other process that the amyloid may also be imparting the clinical syndrome. Okay, so just to let you know, where does A beta come from? This is the amyloid precursor protein, and you can see it's a transmembrane protein. This is the neuronal membrane. This is inside the neuron and outside. So two enzymes are key in cutting this protein, the beta secretase enzyme and the gamma secretase enzyme. And these have been targeted for drug therapy trials for Alzheimer's disease. Unfortunately, they haven't worked, but the idea is to suppress those enzymes and reduce the amount of A beta that's produced to generate these plaques. The A beta peptide is very amyloidogenic, so it sticks to itself in an ordered array and causes these fibrils to form, and this is an EM picture of an amyloid plaque. So, when we think about diseases, we used to kind of think, well, somebody's developing Alzheimer's disease. At the time they're developing the clinical manifestations, the Alzheimer's disease must have just started in them. Well, we know that that's very wrong, and our thinking about Alzheimer's disease is completely different now. And this probably started with the idea of a diagnosis that had been developed almost a couple decades now, called mild cognitive impairment. And this is a condition in which you have memory and other cognitive deficits that are more than what's expected for your age, but not yet. They don't yet meet the criteria for dementia. Okay, and that primarily means that they're not affecting your activities of daily living, because that's kind of the cutoff. Once the underlying disease process has affected your functioning, then that's the definition of a dementia. So mild cognitive impairment was thought to be the earliest sign, for Alzheimer's disease. And we now think of this as a continuum. And as people started to look at the pathology of patients who died with mild cognitive impairment, and even just older normal individuals, there was amyloid forming in the brains of these patients, and it was increased in the case of the MCI patients. And so the thinking now is that, and it's common knowledge in Alzheimer's, is that the disease actually is beginning 10 to 20 years before the actual manifestation of disease. So, that's why it's good to exercise and do all those things for good brain health early in life to maybe stave off Alzheimer's disease later. So this is a curve that shows the onset of clinical disease stages. So this is the preclinical stage, which is long, the MCI stage, and then it goes into the dementia stage. I think rather than go through this whole thing, the main take-home message to this is that this is MCI, and your clinical function is worsening. The higher the curve, the worse things are, and then worsens with dementia. So here's when we can start to, and this is the cognitive problems, here's when we can start to measure a declining cognitive function. And we can't measure it in the preclinical stage, but this is the curve for amyloid beta accumulation. And you can see that it's building up far in advance of the clinical onset of disease. By the time you get to the MCI stage, the amyloid burden is quite high and increases a little bit through the MCI stage. And by the time it gets to the dementia stage, it sort of reaches a steady state plateau. So it would seem that if this was a measure of future Alzheimer's disease, that it would be a good idea to measure that, to be able to measure that. So if you look in the spinal fluid of patients with Alzheimer's disease, you can detect A beta, 1 to 42, and tau. And what's interesting, initially seemed counterintuitive, that in patients with Alzheimer's disease, they didn't have a lot of A beta. So here's a curve that shows tau, increasing levels of tau on this axis, and increasing A beta 42 on this axis. And the black filled circles are autopsy confirmed Alzheimer's disease cases. And what you can see is that they have a lot of tau in their spine. They had a lot of tau in their spinal fluid. They were autopsy confirmed. And low levels of A beta. This is the cutoff for abnormal A beta. And in the normal controls, they had high levels of A beta, but low levels of tau. So if you think about it, it makes sense, because in Alzheimer's disease, you're basically making plaques in your brain. And so the amyloid, the A beta, is being sequestered into or absorbed into the amyloid plaques. So it's being used to build those plaques up. And instead of being released as it normally would be into the spinal fluid, it's being retained in the brain. So the levels go down. The tau goes up in Alzheimer's disease because, and this is a later stage of the disease, because as the disease then starts to kill neurons, then the neurons spill the contents into the spinal fluid, and all that hyperphosphorylated tau is released there, and that can be measured as a specific biomarker of Alzheimer's. So in order to get spinal fluid, you have to stick a needle in someone's back, and nobody likes to have a needle stuck in their back. And if you give them an offer, would you rather get a brain scan, or would you rather have a needle stuck in your back? Most people are going to say, I'd rather have the brain scan. So the amyloid PET came along, and the University of Pittsburgh was the first to show with a compound that they called Pittsburgh compound B, labeled with carbon 11, that this was a compound that, if you can pronounce that, I'll give you $5 at first pass. Okay, if you practice, you can do it. But they labeled this compound that binds to amyloid and injected it into patients. And what you can see is in the Alzheimer's disease patients, there's a lot of uptake, and here in the frontal lobes and posteriorly, cingulate and precuneus, but in control patients, no uptake. So this was really a new door opened as far as being able to assess patients during life for the pathology that was occurring in the brains of these patients with Alzheimer's disease. So there are now 3 agents that are approved in the US, and they have longer life, half-lives, because they have F18 labeled, they're F18 labeled, so florbetapir, flumetamol, and florbetaben are all used in amyloid PETs to detect amyloid in living patients. So the obvious benefits, they're not invasive, and they give us information on the underlying pathology. So you would think that this would be really useful in these Alzheimer's disease variants, especially in cases that maybe we didn't think were Alzheimer's disease in the past. It turns out that they are Alzheimer's disease. So it would be a useful tool to have in regular use. The only limitation really is that, as you can see in the stage of dementia, it doesn't show progression. So once you get into the stage of dementia, it seems to plateau and reaches the amyloid burden reaches a steady state. And so you can't see that patients are getting worse. So you can't use it as a measure of worsening dementia, okay, which we do that clinically anyway. Okay, so this is a control scan, what a scan looks like from one of the F18 compounds. And this is normal control, and the bottom panel is from patients with Alzheimer's disease. The key thing that you can see is that there's a lot of nonspecific binding to the white matter in the normal controls, but no binding in the cortex. As opposed to the Alzheimer patient, there's binding throughout the cortex. And the signal should be at least equal to, if not greater than, the white matter signal. And these regions are the areas that amyloid tends to show up in these scans, and those are the regions that are used in the analysis to determine whether a patient is positive or negative amyloid. Now, the cerebellum turns out to be a good internal control because you get a little white matter, and amyloid doesn't generally deposit in the cerebellum of patients. So that's a useful internal control. Okay, so what I thought I'd do now, that gives you sort of the background to understanding Alzheimer's and what might be the utility for these amyloid scans. What I wanted to do, and wow, time is flying, is give you a few cases. Okay, so these are actual cases in patients in which we employed PET, amyloid PET. So I'll go through them in sort of general terms, kind of just to keep the time give us enough time to ask questions afterwards and finish on time. Okay, so this is an 80-year-old individual. He had a history of hypertension and diabetes, and he noticed some word-finding problems, forgetfulness, and he became a little more irritable after he got an epidural injection of steroids after back pain. And he and his wife both remember that he had the same kind of reaction, irritability after steroids had passed, and they were hoping that all this was connected to that. His activities of daily living were good. He was completely independent. He could drive well, didn't have any problems with that, was taking his medications properly, and he even started an investment business that he was profiting from. His physical exam was normal. He had a little gait imbalance and sensory loss in his legs, which relate to his diabetes. When we screened him with a MoCA, his score was 21 out of 30, which is abnormal. It says that he has at least mild cognitive impairment. He had problems with fluency, so name as many animals or as many words as you can think of that begin with a certain letter, and that was his problem. And he had a poor spontaneous recall that improved with cueing. And this is a picture that we tend to recognize as associated with cerebrovascular disease or vascular dementia presentation, that patients can still make memories, but need some cueing to get to retrieve those memories. And sometimes, though, in early Alzheimer's, that can be the case too. But he was sent for a neuropsychological battery because it was unclear. And the neuropsychological battery essentially showed the same thing we found with the MoCA, that he had impaired memory retrieval, had some language difficulty, and executive dysfunction. So this looked clinically like a picture that could be explained by some cerebrovascular disease. And the neuropsychologist who was doing the evaluation noted that he had some imaging that documented chronic small vessel disease, and she thought that that would explain his profile of MCI. So here's his MRI, and he does have a little small vessel disease. You can see here, periventricular white matter disease. It's not dramatic, though. He does have some degree of just sort of generalized atrophy. There is some hippocampal atrophy. His ventricles are a little bit enlarged. He did have a little thalamic infarct, tiny. You know, he's 80 years old. Is this normal for his age? Did the hippocampal atrophy mean something? Was it related to Alzheimer's? I didn't feel that the cerebrovascular disease was sufficient to explain all of his clinical features, his cognitive problems. So we discussed with the family my thinking, and I gave him the option of watching and waiting and retesting in 12 to 18 months, which is something we often do with patients who don't want to do much else and just kind of keep tabs on it, and see if he progresses and declares himself, or did he want to find out a little sooner and subject himself to an amyloid PET. And so we did the PET. He wanted to do that, and his PET was positive. And this was the reading. I'm a neurologist. I accept the reading of nuclear medicine specialists, but I've learned to read these myself pretty well too. And you can see the internal control, and he has frontal and temporal and posterior parietal to some extent, and precuneus. And so he really had a pretty significant amyloid burden. So here was a guy that had what looked on the surface clinically of vascular-related cognitive impairment, mild cognitive impairment, but actually has underlying Alzheimer's disease. So we changed his management, and we could counsel him better on the future for him. Okay, so here's case 2. Now this is a question of an atypical Alzheimer's disease. So this is a 72-year-old woman with a history of breast cancer, spine surgery, and she had increased confusion, forgetfulness, and trouble finishing her sentences, and some apathy, her husband noted, difficulty with planning and organizing over the past year. She maybe had some gait change, but she did have surgery, and so it was explained as part of the surgery problem, the back surgery. She was also reported to be independent of her functioning, although she did have to make trips back and forth to the grocery store because she would forget things on her list. And she took a wrong turn in the car once and got lost for a bit of time. Her physical exam showed frontal release signs, so a glabellar response and a snout response. And she had some cogwheeling in her left arm, which signified some Parkinsonism. She had some short steps, maybe some shuffling kind of gait related to Parkinsonism, or frontal gait can be short step like that, but other functions were intact. She too had a MoCA that was on sort of this range where I often send people for neuropsychological testing or do additional testing. So she scored 21, and she had problems with placing the clock hands, that alternating sequence of connecting the circles and the numbers, which again is an executive function. She had problems approaching the cue copy, and some problems with word generation that's more often associated with a frontal process, so phonemic fluency. And although she couldn't recall any of the 5 words that were given to her spontaneously, with cueing of categories, she was able to retrieve those words. So again, not the typical Alzheimer picture that she could retrieve those words with cueing, but still could be a hippocampal problem. But the concern for her was that it was more of a frontal lobe disorder because of her apathy, her gait. Parkinsonism is often associated with frontal lobe disease. So we scanned her, and you can see her MRI. She's now 70. She's 72, so not 8 years younger than the previous person, and her brain looks pretty good. And you can see the hippocampi look quite full. So we went to an FDG PET in her, and you can see from a distance that anterior brain has decreased activity compared to the posterior brain. So her occipital lobes were highly, took the tracer up pretty significantly, but she had a decreased metabolism in the right frontal, left frontal, and then in the posterior left parietal and temporal lobe. Now, she did have involvement of the precuneus, which was concerning. Typically with frontotemporal dementia, that isn't involved. So we were still concerned, maybe this is a frontotemporal dementia spreading back, but it could be an Alzheimer's disease masquerading. So we scanned her, and it was also positive. And you can see that this was the read, multiple cortical areas, precuneus, the anterior and posterior cingulate, inferior medial frontal gyrus, and lateral temporal lobes. So, so she was an Alzheimer's patient that, again, atypical, masquerading as a frontal lobe syndrome. Case 3, again, an atypical Alzheimer's disease. I will go faster through this. The bottom line for this patient is similarly aged, 74-year-old philanthropist, had a change in behavior, was becoming more irritable with her family. On occasion, she would ask the same question over and over within a 10-minute period. Their family, some of the family members thought she was definitely having trouble. Others thought she was just being a sort of a moody person and more irritable. She was independent. She managed 4 checkbooks. Her physical exam also showed significant frontal release signs, and otherwise her exam was normal. Her cognitive testing, she was actually seen as a second opinion. She had multiple cognitive evaluations and multiple tests, and she was given a diagnosis of mild cognitive impairment, undefined, and was managed with a cholinesterase inhibitor, which is the treatment for typically Alzheimer's disease, donepezil. And so her neuroimaging looked like this, and you could see that she has atrophy in the MRI on the hippocampus. That does seem to be a little out of proportion here, but she has some temporal lobe atrophy that's pretty significant. Her PET scan showed a decreased activity in the temporal lobes and also in the frontal lobes, with the right medial frontal lobe being more involved. So here's a patient, again, with sort of a frontal lobe appearing FDG PET, features of behavior problems, frontal release signs, and could this really be a frontotemporal dementia, or is it Alzheimer's disease presenting as such? So we did an amyloid PET and her scan. So everybody guess what this one is? And it was negative. So this is a negative scan, and you can see it's pretty dark around the cortex. And so her white matter, there's uptake in the white matter, but the cortex was not active. So this person had actual frontotemporal dementia. So here the amyloid PET helped us to make a diagnosis of non-Alzheimer's disease. Okay, so diagnosis was changed, therapy was changed, cholinesterase inhibitors aren't indicated in that disease, and we were able to counsel the families more appropriately. Okay, so I'm going to skip this for the sake of time. This, I will just say, because this was the poll question, I'm not sure if we have enough time to do the poll, but I was kind of curious. Yeah, okay, so great, it's right up there. Okay, so this is a patient who was 55 years old, and he was pretty much independent in all activities, but his girlfriend said he was more sensitive. He was worried because he couldn't recognize people outside of the workplace. He was a security person, and when they weren't wearing their uniform, he had difficulty recognizing them or coming up with their name. he couldn't read, he couldn't concentrate, he had to keep reading the pages over and over. So a PET scan, amyloid PET, was done, and this is the result. Okay, so the poll is, what do you think? Is this a positive PET scan? So this was a person who came for a second opinion because he actually had the PET scan done. This is an amyloid PET. He had the PET scan done, paid out of pocket for it, which was pretty expensive at the time, just so he could know the answer. He had a strong family history of Alzheimer's disease, and he was quite worried that these were the early signs of Alzheimer's. So I'm not sure how long the poll in progress. Okay, so we'll come back to that. But vote now if you're not sleeping. Okay.
Dr. Mastrianni, we are up to 71% no, 29% yes.
Excellent. Okay, good job. So here, it was reported as probably positive. So this came from an outside institution. I looked at it and I didn't feel that this was positive. You can see it's a little overdone in the signal, the coloration, but there's you can see that there's really a lot of white matter signal, and the cortex, if you look closely, is darker than the white matter everywhere. So it really didn't look positive to me. And I confirmed that with our nuclear medicine specialist. He agreed. So how can we confirm that this patient really didn't have Alzheimer's disease? Spinal tap. So unfortunately, he had to get a needle in his back, but because he was so concerned about it, and the scan was misread by a very good institution here, we did this test, and you can see his A beta 42 was extremely high, and that's a sign of a normal CSF. And he did not have Alzheimer's, so he rested easy. It turns out that he had obstructive sleep apnea and depression, and he's doing much better now. Okay, so I just have a couple more slides. I'm going to just give you the bottom line of this slide. This was a study done called the IDEAS study, Imaging Dementia, Evidence for Amyloid Scanning, which was a huge undertaking. 950 dementia specialists in about 600 sites looked at over 11,000 participants with mild cognitive impairment or dementia of uncertain cause. The bottom line outcome to this is that the diagnosis was changed in patients, in about 35% of the patients. So it went from Alzheimer's to non-Alzheimer's disease in 25%, and from non-Alzheimer's disease to Alzheimer's disease in 10.5%. So so centers had to diagnose the patient, get the amyloid PET, and then determine what the new diagnosis was or whether it was stable. And 60%, so was this useful? 60% of the MCI patients and on the order of 60% of the dementia patients had a change in management due to the amyloid PET. So it seems to be a very useful study in clinical practice. The patients best served by amyloid PET are those with the MCI patients with clinical uncertainty. So is this going to progress into Alzheimer's or not? Atypical presentations of Alzheimer's, which I tried to present to you today, and early onset with progressive cognitive decline. So under the age of 65, which I didn't present a case. And it's getting the most use in research and clinical trials. So in research studies, many centers are performing longitudinal studies on Alzheimer's disease and looking at patients who are unaffected and seeing if they have amyloid in their brain, and then following them longitudinally to see what develops in them and factors that cause them to either manifest disease or not, depending on the time of manifestation. And then clinical trials, just about every clinical trial that's looking at Alzheimer's disease right now has an amyloid PET screen in order to make the diagnosis. And that is the end of the slideshow, and I appreciate your sticking with me for those that are still there. And I didn't do too badly.
So much.
There's only a little time left.
Thank you very much, Dr. Mastrianni. That was a comprehensive evaluation, and thanks for the nice cases. Just for the sake of time, I have one question here I would like to ask you from Dr. Jonathan Appel. His question, do you see a role of combined PET MR scanner in the management of dementia?
Do I see a role in the, say that again, please?
Do you see a role in the combined PET MR scanner in the management of dementia? PET MRI.
Yeah, I'm not sure. Oh, PET MRI?
Yes.
PET scan?
Yeah. The hybrid image.
With, yeah, I'm not sure I understand the question. I apologize for that.
He said, you know, what you showed us, the F18 and the amyloid PET CT scanner, but his question about, do you see a role in the combined PET MRI scanner in the management?
PET MRI.
Yeah.
Okay, sure. Yeah. Yeah, I mean, absolutely. You know, I think the MRI we can do a lot of things with, in addition to, you know, just use it as a marker for location. I think right now the utility for the amyloid scans, the underlying CT scan is really to just localize. But MRI, we can do volumetric studies, cortical thickness at the same time, maybe that amyloid scans are done. There may be a lot of things that you could do with that. So certainly that would be a reasonable approach.
I have another question, and just I would like to give this question, Dr. Mastrianni. Is there any clinical role for PET tau imaging right now?
Okay, so yeah, I didn't talk about PET tau imaging. No, that's not used as a clinical study right now. But you could imagine that it will be, and I think what people are showing is that, you know, the tau may correlate with the onset of the manifestation of disease, and so you can track tau, and maybe you can follow the severity of the disease better with tau imaging as it progresses through the brain. So that may be, you know, the future. There are other cases where chronic traumatic encephalopathy, CTE, is a tau depositing disease, and so that may be more useful using tau in specific diseases like that, or PSP, progressive supranuclear palsy, other tauopathies, and in some of the cases of frontotemporal dementia. So I think there still needs to be a lot of research on applying its utility, but I think it's going to find a big place in clinical utility in the future.
Great. There is another question probably I would like to ask, and came from Joe Doshery. The question was, what makes you decide between FDG and amyloid as first imaging procedure?
Let's see, that's a good question. Well, you know, so in reality, the amyloid PET is not readily available as a clinical tool right now. It's really used in research still. You can get it clinically if a patient will pay for it. Part of the goal of that IDEAS study was to demonstrate to Medicare here that it was useful and maybe would cut down on costs, that if you could get directly to the scan and identify the disease, maybe you could eliminate some costs and help patients in their management. So I think once that gets approved and we can use it routinely, we would probably be skipping the FDG PET and going to amyloid PET more often. And yeah, there may be certain cases that we still need the FDG PET, but I think, you know, once the amyloid PET's available, I think we will probably be stepping to that quicker.
Great. Thank you so much, Dr. Mastrianni. It was a pleasure having you with us here, and we hope that you can join us again in the future. I would like to close this, but I would like to remind everybody that today or tomorrow, you're going to receive the evaluation forms. Please make sure to do the evaluation and send it to us, and a certificate for the CME credit will be emailed to you. Also, our webinar will be available on our website, so you can go and review it, or you can, people who didn't attend in our and today can go to the CNM webpage and review this webinar online. Our next webinar will be in January 27th, so stay tuned for that, and we hope to see you at that time. Thanks again, Dr. Mastrianni. It was a pleasure having you here.
Okay, thank you. It was great to do this. I enjoyed it.
So we hope to see you again in January 27th. Thanks, everybody. Have a good night and enjoy your time. Nicola, you have something to add? Yeah.
Thank you, everyone. Thank you, Dr. Yunus, for moderating this session. Thanks again to Dr. Mastrianni. Hope everyone has a happy new year and happy holidays, safe holidays, and we'll see each other in 2021. Thank you very much. Have a good night.
Bye-bye.